How do you know that?
A lot of dads here.
You have kids? I have kids. My kids would have no idea what is it. They would have no idea about it. Okay, as somebody very kindly pointed out, we're still in the basics, but we're out of the real basics. As a reminder about the real basics, what we talked about in our first lecture, we talked about how the waves that we see on those ECGs, how do they get there? Like, what makes an upright deflection? What makes a downward deflection? Why are P waves upright? What are the two main components that determine if something's upright or downgoing? Positive and negative electrode. Because does it matter if you're 1 day old versus 101 day old on how the electrical conduction is in your heart? Not if it's functioning correctly. It's still going to go from the SA node down to the AV node, down to the bundle of His, and go down to the bunch of brain spots, Purkinje fibers, and we're going to start reporting. So it doesn't matter. Now, certainly we know there are cardiac anomalies that occur because of age and because of other diagnoses or underlying medical problems that can change that. But we're talking right now about a normal heart. And normal electrical conduction is going to be the same from person to person to person in a normal heart. But what changes those reflections on the EKG is where the positive and the negative are located inside the electrode. And we are not going to focus on how. How does the EKG machine do that if I have a positive and a negative over here and a positive and a negative in this one leg? We don't care. What we care about is the end result. Okay? Or at least we don't care today and in this course, right? Because I don't know how the EKG machine does it. It is set up by someone way smarter than me to be able to read that and identify this is lead 1, this is lead 2, this is lead 3. And so that was the first thing we talked about. And then we also talked about what does the P wave mean? What does the T wave mean? What about that QRS complex? And what is a normal QRS complex as far as horizontal time access wise versus a wide QRS complex? So anything greater than 3 boxes wide is considered, 3 boxes is considered wide. We're looking for QRS complexes less than 3 boxes. What about a P wave? Who cares about it? Well, the atria care about it, right? Because it's coming from the atria. So what are the parameters that indicate a normal P wave? You gotta know that. Because as we continue on, we start talking about things like hypertrophy. It's going to maybe affect that P wave and how that P wave is different. So you've got to know what the normal parameters are. T wave. Normal parameters for T wave. Remember T wave, we're talking about, a lot of times we're talking about amplitude, 5 millimeters in the limb leads, 10 millimeters in the chest leads. So we've got to know that because then if we're beyond 10 millimeters, what are my differential diagnoses that are associated with T wave enlargement? So T waves that are longer than normal, high voltage T wave. Right? So today we start looking at the EKG itself and how we're going to read the EKG. Where the first thing we're talking about today is rate, and then we will go into rhythm basics, meaning every time after I look at my rate, how do I determine what the rhythm is? Okay, how do I determine what the rhythm is? It's easy to look, or for the most part, fairly easy to look at a EKG and say, well, that doesn't look right. That looks irregular. That R wave to that R wave to that R wave doesn't look right. That's fine, but we need to know way more than that. What about it isn't right, and what's causing that for it not to look right? Okay? So we've got our rate, our TLOs, and our ELOs. We're going to talk about how, what the different measures are that we can use to determine the rate. Okay, and then we'll go through a couple of examples. Before we do that, let's look and see a little bit of a preview. Where's my paper here? Okay. Abreu Rodriguez. Abreu. Are you, by chance, kin to any of the Abreu pictures? No? But I can say, you shouldn't be here. You should be like, give me some money. Okay, so where are you? Which of the following numbers points to the PR segment? 2, okay, very good, 2. Now, I will tell you what often happens. People get confused with the PR segment. Oh, I know, it's such a good. With the PR segment and the PR interval. PR interval starts at the beginning of the P, goes all the way to the R. PR segment is after the P to the beginning of the R. And when we don't really talk about how long the PR segment is, we talk about how long the PR interval is, or how short the PR interval, and that includes that PR segment in there. All right. Carboneer? How do you say that? Carboneer? Huh? Carboneer. Carboneer. Okay. Okay, Miss Carboneer. All right, let's look at the first heart. Circle it. Here. Okay, we're going to look here. We're looking at the septum, or at least the top portion of the septum in the right ventricle. What leads give us information about the interventricular septum and a little bit about the right ventricle? V1, V2, so you gotta make sure we say V1 and V2 versus 1 and 2, because 1 and 2 is gonna be our bipolar leads, V1 and V2, and a little bit of that AVR, right? So the AVR, we know that nothing truly looks at the right ventricle, but AVR gives us what the best shot that we have. To look at the right ventricle, we'll talk about that later and how we're really gonna look at that right ventricle in a retrospective fashion. Okay, so very good. What about Scagnelli? Scagnelli, what about our middle one? What is gonna tell us information about that anterior wall? Where are you at? Okay, sir.
The anterior wall will be V3 and V4.
V3, V4. V3 and V4, very good. Elliot, Eric Elliot.
It's right here, ma'am.
Okay, sir, what about our lateral wall?
V5, V6, and then AVL.
Okay, so I gotta cut this in half. What are you missing?
Oh, and 1.
1, AVL, 5, 6, 1, AVL, 5, 6. Okay, gotta know that 1 AVL, 5, and 6 is gonna give us information on that lateral wall of the heart, okay? And then Lytton, Dakota Lytton. Okay, sir, what about the inferior?
Inferior. If I remember correctly from this, or 2 days ago, sorry, it was lead 2, 3, and AVL.
Yeah, 2, 3, and AVL, right? You were so I was even nice about it. Nice basketball shot. 2, 3, and AVL. Very good. So those are the things that you're going to need to know for the exam. I say someone comes in, it looks like they're having a lateral wall MI. What area of the heart or what leads would you suspect to find an abnormality in? Okay? Or I'll say you have abnormalities in lead 2, 3 to AVF. What portion of the heart is that? Now, the other thing that's going to happen is I'm going to give you EKGs, and they're going to have abnormalities, and you're going to be like, oh, gosh. And you're going to have to pick those out, and you're going to have to answer. When you take this exam, this is unlike any other exam that you do, because normally you're going to read that stem, okay, let me think about the answers. This, you don't have time for that. Okay, so what you want to do is you want to get a real brief understanding of the question. You need to look at the answers, because otherwise you're going to read that stem and you're like, oh, I know exactly what it is. And it's going to be like, what's the rate? Like, oh my God, I just wasted all this time reading this giant stem. So let me look at the question first, look at my answers, and then I'll gather more information from this stem. Okay. Every time you read an EKG, you've got to read it the same way. So you must have a deliberate approach to reading these ECGs. This is the same approach that I was taught 30 years ago, and it's the same thing that's in Dubin's, it's the same things in Garcia. Okay, so rate, rhythm, axis, hypertrophy, infarct, You're gonna look at your patient, and if we have old ECGs, we're gonna get those as well to do a comparison. So rate, rhythm, axis, hypertrophy, in for clinical correlation, and then comparison with old ECGs as well. We know that in a normal functioning heart, the SA node is gonna be our primary pacemaker, and it's gonna pace the heart at a rate of 60 to 100. Now, occasionally, that heart rate is gonna be less than 60, and if it is less than 60, it could totally be normal. Most of you guys have heart rates less than 60 because you're otherwise healthy, you run a lot, and all those things make for a healthy heart, and we can have heart rates less than 60. But anytime a heart rate is less than 60, even though it can be a normal parameter, we consider that a bradycardic rate. So bradycardia means a heart rate less than 60. Sometimes, just before an exam, or if you drink too many of those energy drinks, you can have a heart rate greater than 100. That is considered a tachycardic rate. Again, could be normal depending on the person, maybe some medications they might be on. But anything greater than 100 is going to be considered a tachycardic rate. And we have to try to understand or determine why these patients might have a bradycardic rate or a tachycardic rate. Because, again, although it may be normal, we want to make sure there's no other reason. We also discussed the fact that by virtue of the way that our heart and our body is designed, we have something called overdrive suppression, meaning if for some reason the SA node doesn't fire, we have other mechanisms in the heart that are put in place to start firing in place of the AV node. The first place is going to be the atria. Atria is going to kick out a beat heart rate of 60 to an 80, meaning we've got the SA node that's in the right atrium. We know that, but this is some other foci in the atrium, some other myocardial area in the atrium that's going to start pacemaking the heart. If that doesn't work, we're going down to the junctional. Junctional, what do I want you guys to think about the junctional as? AV node, that AV node area, 40 to 60. And then the last step, stitch effort, is going to be those ventricles. Someone comes in with a heart rate in the 30s, or probably pacemaking from the ventricles, meaning that we don't have conduction coming from the SA node. Something's blocked there, something's blocked at the AV node, and the only thing we have left is the ventricles. Ventricles said, I didn't get any impulse from above, so I'm going to start firing for this patient. Most commonly, we'll see that as part of medications that people are on, especially an overdose of medications, things like beta blockers. Cocaine is a big cause of that as well, because cocaine blocks out those other receptors and makes them more permeable, I should say, not as permeable to sodium, so now the ventricles end up taking over. So again, this can be affected by medications, but also by autonomic stimulus. We talked a little bit about autonomic stimulus, and we know that through autonomic stimulus, it sends signals to the heart and to the systemic vascular system. So it's going to affect the heart rate, it's going to affect the blood pressure, depending on what part of the autonomic nervous system is affected. The heart is really supplied by two branches of the autonomic nervous system. We have the parasympathetic branch. What's the other name for the parasympathetic? Do you have to remember? Cholinergic. Okay, and then we have the sympathetic, which is the adrenergic. So adrenergic, energy, cholinergic. Okay. And when we think about the adrenergic system, that sympathetic system, that can affect both the atrium and the ventricles, and the chemical or the hormone that's released is epinephrine and norepinephrine. And epinephrine really gets things hyped up, right? Really gets things going. So how is it going to affect the body? It's going to cause that increase in heart rate, increase typically in blood pressure. Not only have an increase in force of the contraction, so patients are going to feel like their heart is racing, but also the heart is beating really, really strong in their chest. This can be that's that fight or flight, right? So this is your fight or flight reaction. You saw a bear down the street, you're running really hard, that's going to activate your sympathetic system. Now, another thing that it does is it can cause increase in irritability of the heart. So increase in irritability of the heart causes other foci of the myocardial area to start beating. Those areas can override the SA node or override the AV node, okay? Or if it's down to override that, and cause these patients to have abnormal heart rates, abnormal heart rhythms, okay, and feel like or even have extra beats that occur. So they may have a normal rate, but then in between that normal, they have like extra beats, and that's when this adrenergic response. The parasympathetic system, that is going to be your slowing down the body and of the vascular system. So decreases your heart rate, decreases your blood pressure. We have dilation of the arteries, okay? And we have decreased contractility of the heart. Now, if you have somebody that comes in and their parasympathetic system has been activated, they're releasing this acetylcholine, and I tell you it decreases heart rate and decreases blood pressure or decreases cardiac contractility, how might they present? You think it might be lightheaded, dizzy, feel like they're going to pass out or did pass out? Certainly, because now we're not having enough circulating volume. Right? So sometimes we can see those changes on the ECG, but when they come in and they complain of these signs and symptoms, lightheaded, dizzy, I think I'm going to pass out, you need to think about what is being activated that's causing this to occur. So those things can increase and decrease our heart rate along with medication. So how do we determine then when we look at this EKG, when we look at this grid paper, how do we determine what the heart rate is? And also, why is that the first thing we look at? Why don't we look for, so you guys, we talked about myocardial infarctions, that's a heart attack, right? Why don't we look for a heart attack first? Can someone have a super fast or super slow heart rate and that kill them before a heart attack? They can. Something like ventricular fibrillation where your heart's doing this, okay? That will kill you before a heart attack. Heart attack, usually if they make it in to see you, we have a little bit of time to get things going. We don't have a lot of time. We're moving fast, okay? But what can kill them even sooner is a heart rate of 400, okay? A heart rate of 20. So the first thing you want to determine is what is the rate? Do I need to be concerned about how fast or how slow this heart rate is beating? Because I may need to provide intervention right now for that rate. So one of the ways we can do this is something called the counting method. The counting method, the easiest way to do this is you find an R wave that is on a dark black line. So what we're going to do is we're going to look at the very bottom of that ECG. The bottom of that ECG is a 10-second rhythm strip. That's how we're going to determine that rate, by using that 10 seconds. Because 2.5 seconds doesn't really give us enough beats in there to help us a lot. So we look at the bottom at that rhythm strip, and we're going to see, is there an area where we have an R wave that falls on a dark black line? And if not, I'll show you how to deal with that as well. But we got really lucky here because this one happens to fall on a dark black line. This is going to be considered your starting point. We have no numbers assigned to this point. No numbers. This is just where we're going to start. Now, we start here. We go to the next dark black line. The next dark black line, if you guys remember, between this dark black line and this dark black line, we have this 0.20 seconds, right? 0.20 seconds, right? This next dark black line is going to be labeled 300. Then we go to the next dark black line. So we start with 0, and we go 300. The next dark black line is 150. The next dark black line is 100. Dark black line 75, 60, and then 50. So we're focusing on the dark black lines. The biggest mistake that people make is they assign 300 to that first R wave. You don't do that. It's the next one. And the reason is we don't have any time that's elapsed. We've got to give it time, and no time for elapse. So who here thinks I'm making up these numbers? Guys, I make up these numbers. Why do we get 300? Like, where does 300 come from?
0.2.
Well, you know, to be kind to you guys, I don't want you guys to have to math too much, but I'll do a little bit of math. So if you were to take out your phones and use a calculator, so I just told you that between one dark black line and the other dark black line is 0.20 seconds. Okay? Well, 2 seconds, how much is that of a minute?
300.
It's 300ths of a minute, okay? Which means between this first black line and this next black line, it's 300ths of a minute, okay? Which means if we go from this to this one, it's 2 300ths, and if you break that down, it's 1/150. Okay, so that's how we get these numbers, right? I wouldn't spend a tremendous of time remembering that, but I would definitely spend a tremendous of time remembering 300, 150, 100, 75, 60, 50. You gotta know that because oftentimes you will use this counting method, and I promise you, I'm gonna ask you a question on the test. Promise you. Don't start at this first R with your 300, you'll get it wrong. 300, 150, 100, 75, 60, 50. And then what happens if we get below 50? We'll talk about that. So what would we think on this ECG here, what is the approximate rate? About 75, right? It's just beyond the 75, so really maybe it might be about a 77 or so. Okay, but we put an average. Is there a difference in 75 to 77? No. Is there a difference between 200 and 210? No. Right, that would solve through that. So we're giving an average of what this is. So this is about 75. Okay. And again, we're going from one R to the next R. One R to the next R. Each of these lines has a number that's associated with them, but we're measuring the time between the first R and this next R. As long as the R to R intervals are regular. If they're not regular, we can't use this method because it's going to vary from R to R to R to R. So if it's less than R50, okay, or if it's irregular, we have a couple other ways that we can do this. We can do something called the 6-second method. 6-second method. And what we're doing is on the ECG, there usually will have little marks. Like on our ECGs at BMC, we have like a little star. And a little star, these little stars will tell you that that is a 3-second strip. So you have a total of 1 star, 2 stars, 3 stars, and that gives you, this is your first 3 seconds, this is your next 3 seconds. It gives you a 6-second area that you determine in the rate. We've got these little marks, 1, 2, 3. So you do 3 little marks, and what you're going to do is you're going to count the R waves in between those 3 marks. So that 6-second strip, you're going to count the R waves. So we are looking at beats per minute. What are we timesing that 6-second strip by? What are we timesing those 3 numbers, the numbers in between those 3 lines by? 10, because 6 times 10 is 60. 6 times 10 is 60. So if we look at this second strip here, we have 1, 2, 3. So this is our first 3 seconds. This is our next 3 seconds. It's a 6-second area. And we're going to count. We have 1, 2, 3, and that's kind of outside. We almost have it in there. So if we take this information, what is our approximate heart rate? It's at least 30. It's almost 40. It's almost 40, but we can't really count that as actually 40. So we can say, though, well, it's in the high 30s. It's probably about 38 or so, 37, 38. Again, we're averaging. We don't have to be perfect. And on the exam, you're not going to have to be perfect. But does everybody understand what we're doing? We're counting these 3 tick marks. Okay, and there's 3 seconds there, 3 seconds there. That gives us 6 seconds. And you're counting the R waves within that 6-second strip. You're timesing it by 10, and that's your number. We also have something called the 10-second method. So if we're using the 10-second method, it actually makes it really easy because that bottom rhythm strip is how long? 10 seconds. 10 seconds. So again, if you have a rate less than 50, or if you have an irregular rate, you need to use the 10-second method or the 6-second method. Can you use the 10-second method or the 6-second method even if you have a regular rate Even if it's, you know, your rate is 80, can you still use those? Yes, you can, but you must use them if it's irregular or less than 50. You can use it for any time. If you're just like, you know what, for the test, I'm gonna study my 300, 150, 175, but in real life, I'm gonna use the 10-second. Great, fine, that's good. You can make the determination, right? But you must use it for the irregular or the heart rate less than 50. So 10-second strip, again, 10 seconds. We know we need to add it up to a minute, so we're timesing the number of R waves on that 10-second strip by 6. 10 times 6 is 60. 6 times 10 is 60. Do we times it by 10? I mean, do we times that 10 second by what? 6. So what do we do here? We count the bottom. 1, 2, 3, 4, 5, 6, 7. So we have 7 across 10 seconds. And so if we have 7, we're going to times that by 6, which gives us about what?
42.
42. About a rate of 42. So pretty slow rate, right? But we're counting from the beginning of this 10-second strip all the way to the end, all the R waves in between. A common mistake is people start counting the P waves. We don't count the P waves, we're counting the R waves, R wave, R wave, and we're adding those together or timesing it by 6 and determining what our rate is. If by chance you're looking at that 10-second strip, you're like, I can't find any R wave that falls onto a dark black line. You can use your calipers. Okay, you can use calipers. You take those calipers, but you can take those calipers and you could place them, on 2 R waves, 2 random R waves. It doesn't matter, but they have to be right next to each other. So you place them here, and then you'll take those 2 calipers and you'll take them and you'll put it on a dark black line, and it'll go to wherever your next dark black line. So you're going to take and essentially superimpose this down here to down here, and you're going to count then between those 2 black lines. Okay? So that's all you have to do if you can't find it, and you just let it mark here, and then you'll count your spaces in between, count your blocks in between. All right, so here is a heart rate. We've got our dark black lines that are determined for us here. Martin Tran. Okay, sir, what do you think if you're looking at this and I tell you that this is, I'm going to tell you this is a 6-second strip. I'm going to tell you it's a 6-second strip. What is your rate? So what are you going to time if it's 6 seconds, what are we going to times it by? 10, okay? So 10s, we have 1, 2, 3, 4. So 4 times 10 would give us 40 or something, right? 4 times 10 would give us 40. Let me see. What do you say, that you can?
Right here, man.
Okay, sir. I want you to tell me what the rate is using the counting method.
Say 300 divided by 5, that'd be like 60.
60. So 300, 150, 100, 75, 60, 50-ish, right? So between 50 and 60, maybe 54, 55, something like that. Okay? And so we know, though, if we look at the bottom, we've got 1 here, and we've got 1 here. So would we, if you had this on an exam, could you use this and say this is a 6-second strip? You can't, because we only have 2 lines. We must have 3 lines in between. So this is a 3-second strip. From here to here is 3 seconds. We're missing the other half. We're missing the other half. Now, you could say, well, I could just times it by 2. Well, it's not advised. It's not advised, because if you keep doing that, we're not even going to be close to what the heart rate is. So determine if you can use the counting method. If not, if you have a 6-second strip, that's fine. If it's something that I want you to be like this, I'll tell you, this is a 6-second strip. Okay? But if it's something I want you to figure out, you better look at the bottom and look for those lines. And we need to have 3 lines at the bottom to tell us it's a 6-second strip. Majority of stuff we'll look at on the exam is going to be part of that 10-second, that 12 lead ECG. Alrighty, so what about this? What about this heart rate? Okay, could we use the counting method for this heart rate? Sure, what would it be? 300, 150, 100. Is it closer to 150 than it is 100? Looks like it. Maybe we're in the 130s or so with this. Okay, so maybe about 130. So if we do our counting method, first one doesn't count. The second one is our 300, the next one is our 150, and then we have our 100. So we're in between that 100 and 150 for that. Okay, so greater than 100 is considered a tachycardic rate, which might be normal. But we're going to try to identify the cause, if there's any underlying cause for that tachycardic or even that bradycardic rate. Bishop. Okay, sir. What are your numbers that you're going to use to calculate when you're using the numbers method, the counting method that you're going to use?
Should be B.
D?
B.
B? Yeah. 300, 150, 100, 75, 60, 50. Okay, I forgot to give you a B. Ready? I know, that takes the heat off. All right, very good. What about, oh my God, Feliciano Rosado. Feliciano Rosado. Okay, ma'am. Is that all that on your uniform? Oh, I was like, I don't remember seeing that long name. Okay. If you have 3.5 beats, 3.5 beats on a 6-second strip, what is going to be your beats per minute? 35, that's it. 35. So we're doing 3.5. We're going to do that times 10, and that gives us 35. And I know a lot of you guys are like, oh, let's just get redundant. I'm telling you, people miss, there's going to be like 2 or 3 of these questions on test, like 2 or 3 people miss them all the time. They miss them all the time, so you gotta just, like those are the give me, right? Those are the easy ones. There's gonna be hard ones, trust me. We gotta get you to get these so that we can counteract those hard ones. Okay, what if you have 12 R waves on a 10-second strip? Torres, Stephanie Torres. Time to math, yes. 12 times 6 is 72. All right, ready? Oh!
Great.
Y'all are really going to have to work on your catching game. Come on. All right. Yes, 12 times 6 is 72. Yep. Okay. When you have that 12 lead ECG, that entire bottom, you know, if I give you a 12 lead, that bottom strip is 10 seconds. Yep. So you don't even have to assume, we know that bottom is 10 seconds. Every time you see the 12 lead, if I'm asking the rate, you can look right at that bottom and you know it's 10 seconds. All righty. Oh, there wasn't that much good on this day in history, but 1908, the first New York City subway was connected between Manhattan and Brooklyn. Now, I got we had an amazing trip a few years ago to New York City, and we took the subway from Manhattan up to the Bronx. And so I hadn't been to New York, I didn't know anything about it. People were like, "You're doing what?" I'm like, "I don't know, it's a subway." But one of the posters on the subway was this poster. Poles are for your safety, not your latest routine. They have the funniest little posters on this subway. I was cracking up the whole time that we were on all the way, I don't know, like an hour and some odd change ride. And so we were there with one of my really, really good friends. We've known each other for 30 plus years. And she's from New York. And we're like, we're taking the subway. She's like, "Oh no, I'll meet you there." I was like, "What's that mean?" I thought it was fun. We didn't have any problem. Anybody here from New York? Is there something wrong with this? Is it bad? I thought it was pretty fun. I mean, this was really entertaining. And it's a good, like, if you're a people watcher, that's a really good place to watch. All right, 1935, Elvis was born. Elvis Presley, Elvis the Pelvis, the king of rock and roll, right? 1935. Yeah, did anybody know that he had a twin? So he was actually born, I think, after his twin. His twin was stillborn at birth. And then he was born after. I didn't have any idea. I had no idea about that. I did know he was in the army, of course, because we have a lot of movies about that. And that's where he met, he was in Germany, and that's where he met Priscilla Presley, because her father was in the Air Force in Germany. I think he was in Freiburg, Germany for a couple of years. So it's pretty cool. And I put this in here because I was recently watching, I don't know, something maybe on the History Channel or something about, I wasn't specifically watching it, El Chapo was on there, but it just happened to come up. So the drug lord El Chapo in 2016 got recaptured. Very interesting, there was a set of twin brothers in Chicago. And they were just trying to make some money. They were married and they started doing like some small time drug stuff, but ultimately became these big kingpins in Chicago. El Chapo heard about it and he got him on board with, he got them on board with him. And so they were doing all this, all these drug sales all over the place, right? Well, these guys knew that the DEA, FBI was on to them. So they knew they were going to go to prison for the rest of their life. So then they made a deal with the DEA and FBI and said, "Okay, we'll help you if you don't put us in prison for the rest of our lives." And they did. And they're the main reason, the only reason why Chapo got arrested is because they would record a whole bunch of conversations. And I didn't really know that about them. We were in, where is it at? Cabo last summer. And we went by one of his little houses, the safe houses, on a trail we were on. I was like, "Oh, that's pretty interesting." Anyway, so that's about all that happened in history. Not that much. Okay, so the first thing we're going to do, we're going to look at ECG. We're going to look at the rate. First thing we're going to do is look at the rate. Determine what the rate is. The next thing we're going to do is look at the rhythm. There's a lot of things that go along with looking at the rhythm. It's not just trying to determine if it's a regular rhythm or if it's irregular. There's a lot of different components that you need to understand. Okay, so we've got our TLOs and our ELOs. We've got to look at all the different components of the ECG that helps us interpret what that rhythm is. We're going to continue on with that deliberate approach. We've got our rate, we've got our rhythm. That rhythm looks at the intervals, it looks at the wave, and it looks at the different segments. So again, we're going to look at that rate first. Is it slow? Is it fast? Is it normal? So is it 60 to 8 or 60 to 100? Okay, or is it above that? Is it lower than that? Then we're going to look at that rhythm. When we look at the rhythm, the best way to do this is look at that 10-second strip. It gives us 10 seconds of what that heart looks like. So we're immediately taking our eyeballs and we're going down to the bottom of that ECG and we're looking at that 10-second strip. Look at your R to Rs. Do your R to Rs look like they pan out like a metronome? Right? Because if they go da 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 da, well, that's not a regular rhythm. That's an irregular rhythm. And if it is irregular, meaning your R to Rs aren't marching out, is it irregularly irregular? Meaning, is there no rhyme or reason? I go da 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 versus dot, 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 dot. Okay, so dot, 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 that is irregular, but it's regular, irregular. Okay? Versus irregular, irregular, right? So the main thing that we talk about when we say something is irregularly irregular is atrial fibrillation. So if you have, and you will have this on your page, you will have a question, you're looking at an ECG, and you note that the rate is irregularly irregular, it's atrial fibrillation on your pants every day of the week. Now, real life, maybe not, but on your pants is atrial fibrillation. So we're going to look at that. We'll look at our R waves from R to R. Is it regular or irregular? How irregular is it? The next thing we have to do in that same area, we're going to look at our QRS complexes. Are the QRS complexes narrow or wide? Now, you'll notice a little bit difference in slides here. Like it'll say the key is if it's equal to or greater than 0.12 seconds or 3 boxes, that is wide. Okay, so if it's less than 0.12 or 11 and below, that is considered narrow. So we have narrow and we have wide. Narrow is a normal QRS complex. And wide is not normal. So if you have a problem with your QRS, what part of the heart is affected? The ventricles. The ventricles are affected. So we're going to look at those QRS complexes. Are they wide or are they narrow? We have to make sure we have P waves that are before the QRS complex. They should be married together. I have a P, I have a QRS. I have a P, I have a QRS. We've got to make sure that that is the case. Okay, are the QRS complexes grouped together? In other words, we have that dot, 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 dot. Okay, are they grouped? And then we have a space. Grouped, and then we have a space. Okay, are there any dropped QRS complex? Do I have a P wave, but I have no QRS complex after the P wave, and then I seem to have another P wave with the QRS complex? We've got to make sure that they're married together. The next thing we're going to do is look at those ST segments. We're looking for those ST segments. Are they elevated? Are they depressed? Because that ST segment should be in a line with our PR segment, which is considered our baseline for the ECG. Again, we're going to look at those P waves. P waves talk about atrial depolarization. The reason why we don't look at them the first thing is because we've got the ventricles that are still working. Okay? But we still want to make sure if those P waves are there. So do we have P waves? Do all those P waves look the same? Because if they're coming from the same focus, so the SA node, then they should look the same. Everyone should be nice and rounded. So when you look at your P wave, like, wait, why does this one look rounded? This one looks tall, this one looks flat. That would be abnormal. They should all look the same because they're coming from the same focus. Okay? And then, again, does each QRS complex have a P wave that is associated with it? T waves, they should be asymmetric. So they should be asymmetric. But do they look symmetric? Do they look flat or inverted? Or are they upright? So normally, T waves are upright and asymmetric. But remember this, that when you think about your QRS complex, okay, QRS complex, I want you guys to remember about V1 and V2. In V1 and V2, our S wave that goes below baseline is deeper, goes more below baseline than our R wave goes above baseline. Remember, we have a little R wave, we have a deep S wave in V1, V2. So with the T wave often will follow whatever is taller or deeper. So in V1 and V2, if your S wave is deeper, it is not unusual to have an inverted T wave. It's going to follow that QRS complex, whatever is taller or deeper. Okay? We want to look at those T waves. We've got to look at the PR intervals. Again, if everything is following the electrical conduction pathway, the PR intervals should be the same. Okay? And they should be within those 3 to 5 boxes. 0.12 to 0.20 seconds is 3 to 5 small boxes. Okay? If it's greater than those 5 boxes, that's considered prolonged. If it's less than the 3 boxes, that's considered shortened. And there are specific things that cause that. AV blocks. If someone has an accessory pathway that cause that. And then PR intervals, again, should be the same. if they're getting, seems to be, well, why does this one seem to be fine, but this one's a little bit longer, this one's a little bit longer, so we take our little calipers, or we take our piece of paper, we measure those PR intervals from one PR interval to the next, to make sure that they're uniform. We've gotta look at that QT interval as well, is it within normal range, is it prolonged, or is it shortened? All right, let's take a break, and then we'll finish up.
No way he's telling that joke right now. He's telling his damn pirate joke.
That's what he just told us. Favorite letter one?
Yeah. What did the civilian do? They went and talked to the battalion commander, by the way?
Oh, yeah, I went back because when I talked to the major battalion XO, they were really helpful. And they were like, the battalion commander kept saying, like, battalion XO was like, yes, ma'am, like, sign the authorized wear thing all the time. And they were like, do you have the memo format? And they were like, our battalion doesn't have the memo format. Just go back and ask them if they have the format, and then they'll give it to you. And I was like, okay, once I get that, do I just send it to you? Do I do it in a car? And he was like, oh, just shoot me an email, and we'll get it signed. And I was like, perfect, okay. And she was like, if they don't have it, come back and let me know. I'll just go with my iPhone, so I'll copy it. Like, copy it. Okay, easy enough. And I was like, I got to go back down there. March my ass back down there, pop my head in. I like see the lady who I didn't talk to the first time, since I just like Gaffney authorized wear. And he pops his head around. He's like this kind of like civilian, like dreaded up, like huge dude, like pops his head around the corner. I'm like, he's like, come over here. Talk to my XO, because I had said like I just came from the XO. And she wanted me to sign, or she wanted us to give you the memo. And I said, yeah,
I will say that it was way better. Yeah, way better.
Still stuck up with the translation. You can't translate. This doesn't mean anything. So I came from there. So he gets out of his desk and he's like, I'm gonna go talk. And he gets up in my face, like he's like this close to me, and he's like, when did you get this award? I said, that's a good point. I got it a long time ago. I should have done it before I left. Exactly. And he starts marching away. And I was like, I get it. He's like, no, you don't. So I'm following him down the XO's office, and he goes, stop. I'm going in alone. I'm like, so I just stay out in the hallway like a kid.
I kind of want to go with mine just to have this experience.
I stayed out in the hallway.
Because I walked straight in with him, like, ma'am, is this how you run your shop? As a battalion commander, this is your S1.
I just like sit there like a little kid, like in trouble in the corner.
Straight up. She's my neighbor. The battalion commander's my neighbor.
Oh yeah? He comes out. He comes out of the S1 office and he goes, okay, yeah, just send it to me. Just send me your documents and give me that. And I was like, I'll just submit your part for you. It'll take too long to do it.
So
I'll get it to you.
So you have to know what
I thought I was gonna
so give me this.
I was like, he's like, yeah, just go make a copy. I was like,
But
here's
you
your
give
copy.
me this.
And he was like, yeah, of course. Like, he just like so friendly. And I was just like,
You don't have them.
You just wait for him like, gotcha.
Yeah. And then I did it, and then that day, yesterday at 2 p.m., it was all approved through this thing.
You start.
I gotta do the same thing.
And I was like, golly, dude.
It's like a 300, 150, 100, 100.
Oh, really?
So then making that comment like, okay, why did you do 150?
It doesn't. It doesn't have to be signed by American Battalion Commander. The German commander saying he completed his course is enough. Because that's all. Mine's uploaded in there. The French might be. It's completely written in French. It has my name, but it has the French commander.
It's a French award. It's
It was just like, I
You don't have the authority to sign off on a foreign award. Like,
Yeah. All I know is that after I left there, I had this like realization.
Are these that's off?
I got to like that every day. Or like, I was in the end, so it's like an order.
Yeah.
I think, okay, I think I'm like, this is shitty.
1, 2, 3, 4, 5.
Yeah,
You walk up to your manager, or like everything we're talking about, every shitty thing that they have to do is like hers.
I was like 1, 2, 3, 4,
I
5.
hate walking into S or S shops and seeing facilities because I'm like,
this could go one or two ways. Ugh. Just the answers. So I know I'm about to get paid.
Set to 6 seconds. 1, 2, 3.
30. 1, 2, 3, 4, 5, 50. 1, 2, 3, 4, 5, 6, 60. What she might say something about this being out of line.
Yeah, you can say it's close
Whatever.
to 60.
I'm saying it's 60. This one I
Because
think is the answer.
This one you can say it's more than 50 because here's your rate. So it's like 50 something. Because like here's your 6 seconds. So 1, 2, 3 boxes.
I think these are the answers.
So you have the same thing as 6 seconds.
If the line up here is heavy 300, be 150. Because that's where she wants to do the calipers. That box, you just move it over.
Yeah, but if she says it's a 6 second shoot, not a 10 second shoot, boxes. But
I'm talking for this answer, the counting method.
oh yeah, just
For that. She said this was a 10 second. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 16.
So far,
Randy said, you tired yet? I said, I'm wired right now. Dr. One next month. He said, I'll check in next week. I said, no test next week? I'll still be doing it.
And that's the first time you saw it?
What is the rate?
not much going on there. They give you a lot of freedom. I'll come back. Maybe try to do.
Sure. It's a Las Vegas way.
That's right.
I got mine.
Yeah. I got my appointment scheduled.
I wonder if
Watch out. You can advise.
Hot.
Yeah, but it was
We don't go.
I'm like, there's no thing back.
Unless you're like.
Plus I have I would be more likely to I have
Yeah.
I would I just pay my vehicle registration.
I think it's not bad.
I just like on top of like
Well, I'm just saying, I don't know. I did hear,
oh, I don't know what I'm gonna do. But I was like waiting for like
oh, Benny.
like, hey man, it's me again. I came in to stop back here with the transaction line that I thought. Walk in, look at her. We go talk to like. As I'm submitting my standing residence change, like, what are you gonna do about this? What are you gonna do with this, huh? Hey, Captain Hanson is I think she gets, no, actually, she said her board isn't even until
I mean, there's nothing she has
MS
to choose.
must be
Like,
Ours is February 17th through
but MS
like March
the only
4th.
thing that would change is
We all go together.
she just wrong.
We just don't get
I
ready.
don't care about that.
Right,
She
right.
doesn't
Yeah, you don't like, you don't have your own. It's like
It's
internal to men's specialty, but like, it's all the same all the time.
And but like
Hopefully
last
she figures that out.
site, some people feel bad.
You know how
like,
she is with admin stuff.
I think
so like if you don't get it,
I have 2 awards that aren't in my file, and I'm just like,
I already have plans and all
fuck
that.
it.
I should have said that. I should have said who doesn't really.
I'm not worried about that. It is more of she wants that version of my
My mom and me made it yesterday.
She
get it.
She liked it though.
Alrighty, so here we go. We do our summary slide. So we're gonna assess that rate, we're determining that rate is fast, slow, or regular. When we think about fast, we might be looking like something like this. So if we were to count these, or do our counting method, that looks a little bit fast, so that's something that's fast. Slow would look like something like this, you've got a lot more spacing between those R waves, and so that would be a slow. Of course, we'll count, figure out what the actual rate is, and we talk about fast, I'm greater than 100, and slow less than, what? 60. Even though our counting method goes to 50, by definition, rate of cardia is less than 60. So it might be fast, we're gonna figure out it's fast or slow if it's regular. We wanna figure out if it's regular rhythm. Okay, this first one, if we were to do a metronome, it's regular, right? And this one, would we say this is regular? It may be slow, but is it regular? It's pretty regular. further, if we were to take our calipers, or again, I take my piece of paper, because on the exam you have to use a piece of paper. I'm gonna take my paper and I'm gonna put it here. And of course, my paper doesn't reach all the way here, but if it did, I would put it there and I put a line right there. And I'm gonna take that and I'm gonna move it over here. And my line should line exactly up. My line should line exactly up, okay? What about this bottom one? What do we say about that? Irregular. I take this and I put my line here and I put my line here and I move it here. They don't line up. That lines up. That doesn't line up. Irregular. Okay? And again, those are pretty obvious, but sometimes it's not so obvious. Sometimes you're looking at it like, I don't know, I'm not really sure. Get out your caliper, get out your piece of paper, and really make sure that that is in fact regular. We want to make sure if it's regular or irregular. And again, yes, it's wordy, but irregular is a thing, and we specifically will see that with something like atrial fibrillation. We want to use those calipers in real life, not an exam, and that helps us. If you put the pin, so a little pointy part of the caliper on the first R wave, or the one R wave, the very next R wave, your caliper, the other point of that caliper goes on there, okay, and then what you're going to do is we call it walking or swinging the calipers. So on this second R wave that you put this on, the pin stays there, and you're going to walk the calipers to the next R wave. You should not have to adjust those calipers. Okay, if it's regular, we're going from one R wave to the next R wave to the next R wave. We shouldn't have to adjust the calipers at all because it's irregular. If you have to adjust the calipers, that tells you that's an irregular rhythm. We want to look at those QRS complexes greater than or equal to 0.12, which is 3 boxes. 0.12, 3 boxes is considered a wide QRS. Wide QRSs indicate something going on with the ventricles. Something going on with the ventricles. What we want to look to see, is it wide or narrow? Narrow is less than that, so 0.11 and less, or less than 0.12. Okay, and are the QRS complexes, so the first one here, we have this, what would we say that is? Wide or narrow? Narrow. Next two are wide. And some people will get confused on this third one, but look, we have the beginning of our R here, R comes up, R comes down, this is our S wave, and S wave comes back up to baseline. So QRS complex, not QR complex, QRS. So if that S wave is wide, then you're going to have to follow it till the end till it comes back up to our baseline. Okay, so we've got our narrow and we've got our wide. Are those QRS complexes grouped? Okay, so we've got a couple here. Ducked up, space, tucked up, space, tucked up. So those are group QRS complexes. We call that bigeminy. Now in general, we don't think a lot about bigeminy, but sometimes when someone comes in and I'm having palpitations, and they're bigeminy, sometimes it's because they drink a lot of them energy drinks. Okay? So some of y'all probably like, oh, sorry, heart rate right now. But sometimes it's from energy drinks, sometimes it's from drugs. When they come in, we see that it might be okay, but a lot of times we think about potentially what the underlying cause is. Do we have any dropped QRS complexes? Do I have a P wave, but it's not followed by a QRS complex? Because if I have normal conduction from the SA node to the AV node down to the ventricle, I should have a P wave, I should have a PR segment, and I should have a QRS complex. Right? So what, do I have dropped segments? P, QRST, P, QRST. I've got something here. Now, some of you may be like, well, how do I know that's not a U wave? How do I know that's not a U wave? Because if you were to measure this out, if you were to measure this out, okay, and you say, okay, I got a P here and I got a P here, well, guess what? Those P waves line up exactly. That means the atria are depolarizing appropriately, but something has blocked that depolarization going down to the QRS complex, and now I have a dropped beat. Okay, a dropped beat. So we want to make sure that we have P, QRS, And that would indicate that we have appropriate depolarization down to the ventricle. When we're looking at this information so far, so we're looking at the QRS complex, we're looking at regular, irregular, rate. What you're doing is you're looking at the bottom rhythm strip. Look at the bottom, so when you get that EKG, look at the bottom rhythm strip. It's going to tell you all the things that we talked about so far, what the QRS complex is, rate, and if it's regular or irregular. Now, once we get to the ST segments, we're looking for really primarily infarction or ischemia, so elevation or depression. If you only look at lead 2, for ST segment elevation depression, does that tell you about the entirety of the heart? What does lead 2 tell you about? What part of the heart? Inferior. Well, what about the rest of it? So if I say, oh, lead 2 looks great, well, good. I'm happy that lead 2 looks great, but that's giving me one little part of the heart. I need to look at the rest of it. So now, my eyes are going from that 10-second strip up to the main portion of the ECG. Prior to this, I haven't looked up there that much. I've been looking down here to give me the rest of my information. I'm now going up to the main portion of the ECG. When you go up to the main portion of that ECG, you need to put lights with lights. 1 goes with AVL and V5 and V6. So I'm going to look at 1, I'm looking at AVL, look at V5, V6. Do I have ST segment depression or elevation? Do I have ST segment depression? Looking at 2 or 3 AVL. Depression, depression. Elevation, depression. Okay, V2, V3, or V1, V2, V3, V4. Gives me septal, gives me anterior. When you go up to looking at the top portion of the ECG, put your lights with lights, look for that elevation, look for that depression to see if you have that. This top one, we look at this is our PR segment here. We've got our ST segment that's right at baseline, that looks appropriate, right? So if we look at this next one though, we can see that we have a little bit of elevation above baseline. That might be okay. We talked about 2 millimeters, anything greater than 2 millimeters would be concerning. But if we only looked at lead 2, we may not see that at all. Maybe this is an early infarct. Maybe the patient came in 20 or 30 minutes after chest pain and is now infarcting, actively infarcting. So we're going to repeat that ECG. Okay, but if you look at only at lead 2, you may not see this because it may be in those lateral leads, maybe in the anterior leads or the septal leads. And then this bottom one would be an indication of ST depression. Again, we're going to do the exact same thing, look up in that main portion of that ECG. Okay, now, P waves. Let's go back down to that rhythm strip. We're going to look P, 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 P. We ideally will see PQRS, PQRS. Do the P waves, when are they there? Okay, do they all look the same? So if we look at this first little rhythm strip here, I know that if you look at that, some of you are like, well, yeah, maybe. No, we should clearly see P waves. We should clearly see P waves. So if we look over here, okay, we can see a whole bunch of stuff, right? But P waves should look like this. P wave, I clearly see P waves. You guys see the difference between those 2 little small sections, those 2 rhythm strips? Where the first one you're like, well, I could imagine P waves, but I may not clearly see P waves. But this next one, the one below that, I mean, I see a P wave, I see a P wave, I see a P wave. So that top one, that's atrial fibrillation. That is atrial fibrillation. It's not that the P waves aren't there, they're just not being conducted very well because the atria are doing this. Okay? The atria are doing this. And sometimes you will see a very clear P wave. So that is something that we don't really see clear P waves. Now what about this next one? If you look at these P waves in this next one, the next top one, do you guys see P waves? Do the P waves look the same in every single one? They don't. They don't. And what that means is something more than one foci in the atria is depolarizing. It's coming from more than one foci, because if it was coming only from one foci, whether it be the SA node or somewhere else in the atria, if it's one foci, then we're gonna have the same P wave. It's gonna look the same. So this is your indication that there's multiple areas of the atria that are sending off signal. And multiple areas are fighting over domain on who is gonna be the primary foci for depolarization. You're gonna see that in the P wave because the P wave represents our atria. If we look at this bottom one, do we have each P wave that's followed by a QRS, or do we have a P wave before each QRS? So if we have a P QRST, do those P waves look the same? Pretty similar, right? But what is the problem that we have here? There's no P wave. And if there's no P wave, what does that indicate that is not happening? The atria is not depolarized. We're having ventricular depolarization, but for some reason, the atria didn't depolarize. So that overdrive suppression kicked in. And what happened is that junctional area took over, and then it kicked it down to the ventricles. We got our QRS, so ventricles depolarized, but for some reason, the atria didn't depolarize. What do we see what's going on here? We got PQRST, 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 and what do we have here? We have a P, but we don't have a QRS. So again, something is blocked. Atria depolarized, but the depolarization didn't get on down to the ventricle, right? They were blocked somewhere in the AV node. Sometimes it's a complete block where you don't get a depolarization, you don't get a QRS at all. Sometimes there's a delay in the depolarization, and you'll see that QRS complex occurs a little bit later than normal. All right, we're gonna look still at that bottom strip. Okay, we've looked up there for the ST segments for the rest of the EKG, but now we're back to that bottom. Let's look at our T waves. Are they asymmetric or symmetric? And what do they look like? We should, for the majority of our leads, they're going to be upright. Okay, so if they're flat, we might indicate some sort of electrolyte derangement that might be causing that. If they're inverted, okay, that might be normal. If the majority of that QRS is downgoing, might be okay. But what we shouldn't have is those real tall ones, greater than 5 in our limb leads, greater than 10 voltage. In our precordial leads, we shouldn't have those real tall T waves. And they shouldn't look real wide and crazy like this one. This is concerning for some sort of CNS, some sort of hemorrhagic problem in the brain, some sort of stroke probably. Typically you want that slow upslope and then that quick downslope. Slow upslope and quick downslope, not real peaks and not flat or inverted. Now, I want to point out something here. So let's look at this one. When I talk about the QRS complex being more positive, more negative, this is abnormal. It's abnormal because our QRS complex is more positive than it is negative, right? It goes up above baseline, our R, more than our S wave goes deep. So that T wave inversion would be abnormal there. If instead we had a deep S wave here and only a little ditzel of an R wave, would not be abnormal at all. You could see that T wave inversion. You gotta look at the QRS complex and see how that QRS complex appears, more positive or more negative. PR interval, 3 to 5 small boxes. If it's greater than 5 small boxes, it's prolonged, meaning something at the AV node is, we have a delay. More of a delay than what we would expect to be normal. And if it's short, things are getting down to the ventricles quickly. We have an accessory pathway or maybe medication that's allowing that depolarization to occur quickly. In this top picture, okay, does everybody agree that this is a P wave? Right here, P, QRS. Does everybody agree that this is a T wave? What do we have here? Another P. We have another P. The problem with this P wave is it's way far away from our QRS complex. Why is it way over here, but this P wave is right on point? So we can see that this P wave is before here, but again, far away. Our PR interval PR interval is varying from beat to beat. We've got long here and then close here and then long here and close here. That's abnormal. Something at the AV node is not right because we're not having consistent depolarization down to the AV node. Yes, sir.
How would you determine the difference between just a drop versus a elongated?
So what you're looking for is you got to measure out P to P to P to P. You got to measure out QRS, 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 QRS. If it's just a drop beat, there's going to be a QRS, or when you measure it out, you'll have a spot like, wait, a QRS should be right here, and I have a P, but I don't have a QRS. Okay? So everything should still march out for you, okay, but it's just we don't have if we just don't have conduction, it's just not going to be there. So for this, okay, so we have our P here, but if we measure these QRS complexes out here to here to here to here, if you look at those, don't they look pretty regular spaced, the QRS complexes? So that tells you it's not a dropped QRS complex. It tells you the problem is with the atrium, the problem is with the P wave. So very good question. Yep. Okay, what about this next one? So we have our PQRST. Okay, if we look though, look at that little tiny PR segment. Okay, about might be normal, but then when we look at the next one, why is this P further away? And why is this P even further away? And now, sir, we have a dropped QRS because our PR segment got longer and longer and longer to the point now we have a total block of depolarization. So when we look at our PR intervals, you've got to take the time to measure. Most of the time when you look at it, you'll be okay, yep, it looks pretty good, right? But if you have any indication that you are taking your paper, you're putting at the beginning of one PR segment, mark it here, and move it to your next PR segment, move it to your next PR segment. Because sometimes these blocks are very subtle, but something is occurring at the AV node. QT interval, we know, you guys already know that you need to know the numbers, 350 to 450, 360 to 460. And you need to know less than half of the R to R. Okay, but we want to know, is it normal? Okay, is it prolonged? Prolonged QT interval is not good. It's not good. These patients are a high likelihood of a fatal arrhythmia. Okay, something like a torsades. Okay, and sometimes they can come out of it, and sometimes they can't. We don't want, I'd much rather have a shortened QT, kind of, than I would a prolonged. I don't want a shortened one, really. I just want a normal QT. Okay, but we want to look, is our QT normal? So when we look at this top one, do we think that's normal? From our Q all the way to our T, it looks pretty short. Okay, if we were to count the boxes, it looks pretty short. So we say about 9 to 13 boxes or so. So that looks pretty short, but we also don't want it real long like this one. We go from our Q all the way to the end of our T. Not the middle of our T, not the beginning, the end of our T, beginning of our Q. If there's no Q there, you're going to go with that QRS complex. You're going to start with the R wave. How do we know, like a kind of a real quick assessment, when we look at the ECG, how do we know it's coming from the SA? How do we know the initial depolarization is coming from the SA node? What you can do is you can look at lead 2, and you can look at AVR. You should have an upright P wave in lead 2, okay, upright P wave in lead 2, and then we have our QRS complex, okay, and then in AVR we should have an inverted P wave. Upright in 2, inverted in AVR is your indication this is coming from the SA node, at least initially. Meaning we start here, we got upright here and down going here, fine. Okay, but we may look down here like, yeah, but I'm missing a beat. Doesn't mean it's not coming from the SA node, it means something blocking it from getting down to the ventricles. Okay, so upright in 2, down going in AVR for our P wave is an indication that this is coming from the SA node. Now we need to determine is it a normal sinus rhythm between 60 and 100? Is it a bradycardic sinus rhythm, so less than 60, or is it a tachycardic sinus rhythm, which is greater than 100? Ooh, a couple facts for fiction. CPR, does it require mouth to mouth?
Shooter's preference.
It used to, but really nowadays it's, right, push on chest as fast as you can. Ooh, I like this one. Oh, wait, I gotta ask somebody this one. Wesselman, Joseph Wesselman, what do you think about the fingernails? Where you at? Okay, so what do you think about the fingernails? Do they grow at different rates? You think that they can? Okay. Which one goes fastest? Yeah. This finger right here. That's what the studies show. I mean, I don't make it up. That's what it says. I mean, you know, I can't help what the studies say. The studies say they do in fact grow at different rates, and it's the middle finger. Okay? All right, you're going to be asked this question a million times, and this says adults, it's adults and pediatrics. My baby, they hit the head. We keep them awake all night long? I think some people are like, yes, maybe, do we? We used to, every hour, wake them up, wake them up. But no, not anymore. The studies say that's actually detrimental because they need rest. Now, certainly, you got to check on them. Okay? You want to make sure they're breathing. If they wake up, you want to check their eyes and make sure their eyes can focus. But in general, we don't recommend any longer waking kids up that have a concussion or hit their head. You allow them to sleep, you have brain rest, and that will help them. This is our summary. Rate, rhythm. Look at the QRS, ST segments, P waves, T waves, PR segment, QT segment. Okay, that is our summary. When we're looking at this entire ECG, don't get overwhelmed. Don't get overwhelmed. If you, especially for those of you that know a little bit about ECGs, you're going to start picking out a bunch of crap on these ECGs and be like, oh, I see this, see this. I'm not even asking about that. I'm not even asking about. So focus down at the bottom portion first. Look at your QRSs. Look at your P waves and your QT numbers, your PRs, and all those things. Okay, once you get to your ST segments, which is kind of the second thing you look at, bring your eyes up to the rest of the ECG, put lights with lights, make sure you don't have ST segment depression or elevation, and then come back down to the bottom and finish up your evaluation of the ECG. Willis. Where you at, Willis? Oh, Gary. Okay, sir. What do you think the rate is for this? You're like, oh, I can do that one. I said rate. Yeah, 66. So one of the things about using the 10-second method, let's say we had 20 R waves across. Oh, you only know it's 20 because I told you 20. Otherwise, you got to count. It takes a long time. It really takes a long time. So if you just did the 300, or the counting method, 300, 150, 100, 75, 60, you're done. So sometimes, the majority of the time when I do it, I just use the counting method because I train myself to use counting. It's much easier for me, right? And in general, so if we look at this, okay, 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000. I'm already 8 or 9 seconds in of counting this. I could have been done in 3 seconds with my counting methods. I got to count all these R waves. If there's 20 of them, it's really going to take me a long time. So even though you can choose to do however you want to do it, sometimes you need to be a little bit quicker on the ball when you're identifying which rate. And yes, at the top of your ECG, it's going to tell you what the rate is. But you need to know how to calculate it. Because I don't believe anything that machine says except for the QT. Because I'm not calculating that QTC. All right. All right, we're almost done, folks. DAS. Sylvester DAS, where are you? Are you there? Yeah. Right there. Oh, you sir. Okay. Rate. What is rate? There's 5 R waves on a 6-second stretch. 50. Oh, now that was me. Hey, that's my N of, like, I've run a lot of them, that was only one that. All right, 50, because we're doing our raise, we have a 6-second strip, so we are timing that by 10. So 5 times 10 is 50. All right, very good. Magdarrad. Is that how you say that? How do you say it? It's not even close. Well, how do you say it? Madeirov. Madeirov? Okay. All right. Tell me what you got here. The top ones. Tell me what you think this rate is on the top. Counting method, right? So very good. Counting method, we have 300, 150, 100. Very good. And what about the bottom one? $60. Can we use any other method? We don't have enough information. Right? We don't have enough information to use any other method. So luckily, it fits within our parameters. Okay? You're not going to have anything like this on the exam. The majority of the stuff we'll have is either going to be a rhythm strip, but most of it's going to be a 12 ECG. All right. So what about number 1 for? I mean, do you have all this on your name tag too? Lau, Audello,
No, just loud.
Solis?
Just loud.
Huh? Just Lau. Oh yeah, Lau. Okay. What about you? What do you say? What say you on number 1? So rate.
30
30. So what do we do? How do we do that?
with 6 seconds.
6 seconds. And we're timing by 10, right? Okay, very good. Now, could we use the counting method on this?
It's for very time consuming.
Can't, right? Because we only go to 50 on our counting method. We only go to 50 on our counting method, and this is rated 30. All right, very good. What do you think about number 2? What do you think the rate is there?
And
50. 1, 2, 3, 4, 5 times 10. And then this bottom one, we have 1, 2, 3, 4, 5, 6. So that gives us about 60. We could technically use the counting method for that. And we can do it for 2 technically. But those are pretty easy. Right? Okay. What about this one? Miller. I can say that one. Miller. Sam Miller. Okay, sir. About 140, you say? Okay. And so if we look here, we can see that there's an R pretty much right on that dark line. So we've got 300, we've got 150, and we're just a little shy of 150, but way more than 100. So yeah, 140 or so, 140 or so, probably okay. Again, we're looking at averages, Could you do the counting method? I mean, could you do the 6-second method or 10-second method?
6 seconds.
Yeah, we don't really have enough information. We only have one line. That's not gonna help you. We gotta do that. That's fast, right? What? What happened?
There's one on each side.
Cut off.
Very lightly.
They're in there.
Oh, I see it. Yeah. I guess it.
Technicality.
Well, we could. We can count them all up. 1, 2, 3, 4. See how long that takes? It takes forever. Oh, can't even do it. What do you think about this? Is it the rhythm? What do you think about the rhythm? Fast, tachycardic, and regular, irregular?
Irregular.
Okay. All right, got that, and what do we have here for our rate? Christopher Martinez.
66, ma'am.
60, how do you know that?
Because it's a 10-second strip, so you multiply the R's times 6.
How did you already look at this? You was looking ahead? 66, you said?
Yes, ma'am.
How many R's are on the cross bottom?
11, ma'am.
11 times 10.
11 times 6.
6. Yeah, 66. All right, fine. What if we had to do the counting method? What's your thoughts on the counting method?
So then I can do the first one, so 300, 150, 100, 75, so between 75 and 50.
60, right? All right, so close enough. Very good, very good. And let's look at this rhythm. What do we say about this rhythm? Irregularly irregular. Irregularly irregular, right? So that don't make no rhyme or reason. We don't have two that are together and then spit. So that's atrial fibrillation. It's atrial fibrillation. We don't really see any good P's. We see some T's. And it's a fast, actually we call that atrial fibrillation with rapid ventricular rate. Because people have atrial fibrillation, it could be a normal rate, but this is a fast rate. Alrighty, that is all. We'll see y'all tomorrow.
I'm just